I'm Sakura, and I will begin our presentation on back pains by defining the problem. A description of disease back pain. The back has an important role to support body weight and motions needed in everyday activities such as twisting and bending. Back pain originates by being out of shape and/or a disruption in the structures of the back. Symptoms of back pains can vary from dull aches, stinging or burning sensations, and in severe cases can cause tingling in legs and feet, muscle spasms, and tightness. Local situation. Data from the Global Burden of Disease estimated that 10% of the New Zealand population are suffering from lower back pain. The measured disability adjusted life years by the Global Burden of Disease ranked lower back pain as the 7th largest promoter of health loss in New Zealand. Lower back pain is classified as a back disorder in the summary of the DELIs, and the DELI count for the back disorder was 27,112, and the percentage of the total DELI was 2.7%. Additionally, over $130 million a year is spent in New Zealand by ACC to treat injuries related to back pain.
My name is Hannah. On a global scale, lower back pain is the leading cause of years lived with disease. The data below is the age standardized by gender graph. We can see a rapid upward trend as the prevalence increased by 200 million people from 1990 to 2017, peaking between ages 80 and 90 years old. Additionally, lower back pain is more prevalent in females in comparison to males. This study was published in NCBI, where the countries listed below to the part.
Hi, I'm Maddie, and I'll be talking about back pain amongst Māori and Pacific people. So the yellow flag score system is a way to identify how at risk people are going from acute lower back pain to chronic lower back pain. So the medium yellow flag score for lower back pain amongst Māori is the second highest medium among ethnicities in New Zealand, as can be seen in figure 1. Of those whose yellow flag score is between 50 and 89, which is moderate risk, and 90 and 105, which is moderate to high risk, Māori had the third highest prevalence. Pacific Islanders had the lowest risk of their acute lower back pain becoming chronic and are more likely to only have moderate yellow flag scores.
Hi, my name is Sam, and I will be talking about another risk factor, which is age. The prevalence of lower back pain in elderly people aged 45 to 60 is almost double the prevalence in individuals aged 18 to 29. This is just due to the fact that as you get older, the strength of bone deteriorates, and at the same time, muscle elasticity and tone decreases, which results in more stress on the back.
Another important risk factor of back pain is obesity. According to the 2019 Ministry of Health data, obesity rates varied between ethnicities. Pacific communities had the highest rates at 64%, whereas Asian communities had the lowest at 15%. However, a common trend found across all groups was that people of lower socioeconomic status were more likely to be obese. According to the Ministry of Health, low socioeconomic status is one of the major inequities related to obesity. Residents of more deprived areas are 1.8 times more likely to be obese in comparison to lesser deprived areas. Data obtained from NZDEP, which raised decile 9 and 10 areas such as Northland, having a 73% obesity rate. This figure is significantly higher in comparison to other New Zealanders.
Hi, I'm Nishith. Now I'm going to talk to you about the causes of socioeconomic inequity. So socioeconomic status refers to the economic, social, and work position of an individual. Low SES communities have reduced levels of education, rate of employment, and low household income. Those with poor health are likely to be in low SES due to their reduced ability to work. The stress of a low SES lifestyle and maternal deprivation result in a poor health status. This results in a cycle of impoverishment, which is on the right. It shows all the factors contributing to poverty.
Hi, I'm Petra, and I'll be presenting on what mechanism increases the inequity. There is an excessive amount of fast food outlets selling less healthy food in more deprived neighborhoods. For those living in low SES communities, fast food is a cheap and practical option to feed individuals and families, and this has a direct relation to increased rates of obesity in communities of low SES. So this graph shows the median travel distance to the closest fast food restaurant in different deciles. In higher decile communities, there is a significantly lower travel distance, meaning that fast food outlets are more accessible compared to lower decile communities.
Hi, I'm Shiza, and our proposed intervention is the National Healthy Food and Drink Policy. The New Zealand Strategy District Health Board Toolkit proposes an intervention known as the National Healthy Food and Drink Policy, which is funded by the New Zealand Government. It consists of overarching principles that reflect the Ministry of Health's eating and activity guidelines for New Zealand adults. It also has a more specific criteria to support caterers to put the principles into practice and was designed to help reduce the rates of obesity in Aotearoa. The setting of the intervention is within food consumption environments, which includes homes, schools, worksites, and restaurants. The original first edition of the National Healthy Food and Drink Policy was first established in 2015. Since then, it has gone under extensive review, and in 2019, the second edition was published. We will be proposing the second edition of the National Healthy Food and Drink Policy, which primarily focuses on ways to make the policy more practical and easier to follow. The National Healthy Food and Drink Policy was developed by the Healthy Food and Drink Environments Network, which involves a group of nutrition, dietetic, food service, and public health representatives from all DHBs along with the Ministry of Health. It also receives support from the University of Auckland, the Health Foundation, and Activity and Nutrition Aotearoa. The goal and purpose of the National Healthy Food and Drink Policy is to prevent obesity and disease while advocating for healthy food and different food consumption environments, as well as to provide food outlets with the criteria to identify the different zones and classifications of food to promote healthier food and drink options with staff, visitors, and the general public. The target population for the intervention is staff of organizations, visitors, and the general public in Aotearoa. The policy will be implemented to the target populations by organizations promoting healthier eating behaviors to staff, visitors, and the general public through the delivery of consistent evidence-based nutrition messages. Each food outlet organization will have their own implementation plan, which will be aligned to the agreed expectations of the network and the Ministry of Health. But they will also be required to follow the principles of the policy so that it is able to be monitored by the government in a signed agreement. The rationale for selecting the National Healthy Food and Drink Policy was because changes in food consumption patterns over the years have led to increased rates of obesity, which is a huge risk factor and a main cause for back pain. Studies in New Zealand have found that the trend of eating food away from home rather than home-cooked meals is ever increasing, and the trend on eating out and relying less on home-cooked meals is set to increase. The National Healthy Food and Drink Policy helps to build a food environment that aids to the maintenance of healthy weight. This is important as maintaining a healthy weight helps to reduce the risk factor of back pain. Being able to manage your weight through proper nutrition, diet, and exercise is key to reducing and preventing back pain, which is why we have proposed the National Healthy Food and Drink Policy as an intervention to help reduce the prevalence of back pain in New Zealand.
The Ottawa Charter is a health promotion strategy which acknowledges that good health is a basic right for everyone and requires collective and individual responsibility. The National Healthy Food and Drink Policy fulfills the build healthy public policy, develop personal skills, and create a supportive environment strands of the Ottawa Charter. And we will discuss how this policy relates to the developing personal skills strand of the Ottawa Charter. Develop personal skills is a health promotion that supports an individual's personal and social development through providing information and education for health. The purpose of the Healthy Food and Drink Policy is to evaluate the criteria of the different classifications of food and drink, ranging from healthy to unhealthy. At an individual level, people can evaluate their current lifestyle and eating habits and work to improve their health by choosing healthier foods using the Healthy Food and Drink Policy. This policy allows individuals to develop skills on a personal level using the classification criteria of red, amber, and green zones to classify foods within their home as healthy or unhealthy. This information can then be used to educate them on low-fat, serving energy foods, which can help to reduce the consumption of unhealthy food. Overall, this helps promote consumption of healthier eating patterns at home.
The Healthy Canteen Policy aims to implement the school-based nutrition policies that restricts the sales of unhealthy food classified as red or banned and encourages schools to fill the menu with healthy items classified as green. The study method is a randomized control trial that's conducted on primary schools with a canteen in New South Wales, Australia. The study investigated the implementation of the intervention of the Healthy Canteen Policy over a 14-month period. The outcome measured was the number of food classified as red or banned removed from the canteen. When hanging the study on the gate frame, we see that the participants are the 70 primary schools in New South Wales, Australia with canteens, and that these participants are equally and randomly allocated into the exposure groups and the comparison groups. We see that there's 35 schools allocated into the intervention and that there's 35 schools also allocated into the control. Over the 14-month period of the study, we see that the exposure group has 27 schools that removed food classified as red or banned from the canteen, and 8 did not. And in the comparison groups, 30 schools removed food classified as red or banned from the canteen, and 5 did not. The exposure group occurrence is 771 per 1,000 primary schools canteens over 14 months, and the comparison group occurrence is 857 per 1,000 primary school canteens over 14 months. Comparing EGO and SEGO, we see that 86 fewer primary school canteens per 1,000 that were exposed to the intervention implemented the school-based nutrition policies over the 14-month study period. The results showed that the exposure group are less likely to remove food classified as red or banned by the school-based nutrition policies than the comparison group. And to conclude, the study showed that the intervention is poorly implemented in the primary schools in New South Wales in Australia.
We chose the Healthy Canteen Policy study because it related to our intervention and provides evidence. There are many parallels between this study and our intervention, which is why the two arrows. The study restricts the sale of unhealthy food in a school-based environment, and the aim of the study is to prevent child obesity. This is similar to our aim to reduce obesity, which we identified as a risk factor for back pain. In summary, the multi-strategic intervention to enhance the implementation of healthy canteen policy can be used as evidence to support our intervention of the National Healthy Food and Drink Policy.
Critiquing the study using Ramberman, the allocation process was done sufficiently. The participants were allocated into the exposure group and the comparison group through a randomized process, which meant that all the participants had an equal chance of allocation into EG or CG, which made the two groups very similar at baseline and therefore reducing any confoundings in the study. The random allocation of the participants were actively controlled by the investigators. This usually raises some ethical issues. However, the participants provided consent prior to the study, which made this particular study ethical. Blind measurement. The study is a single blinded study where the investigators are unaware of the participants' exposure status, but the school staff, such as the principals and the canteen managers, were not blind to the group's allocation. Despite the fact that it's a blinded study, outcome measurement errors could occur if the school staff are aware of the canteen menus, as they could have their own opinion as to what's healthy and what's not healthy for the children.
The multi-strategic intervention of a healthy canteen policy study is a randomized controlled trial. An RCT is a study where participants are randomly allocated and the outcomes are measured over a period of time. In the study's 14-month follow-up period, a total of 13 schools among exposure and comparison groups was lost to follow-up. Within the exposure group, 8 schools were lost to follow-up. 2 schools dropped out because their canteens were no longer operational, and 6 schools declined to participate in follow-up data collection. In the comparison group, 5 schools were lost to follow-up, where 2 schools dropped out of the study due to the canteen no longer being operational, and 3 schools declined to participate in the follow-up data collection. There is maintenance error in the study as the participating schools in the study were lost during the follow-up period. This underestimates the true effects of exposure in the study outcome.
A proposed intervention is mandated by legislation. This is a really important aspect of addressing the inequity, socioeconomic status. Because everyone is affected by the policy, areas of high and low SES will have access to healthier consumption options. However, this is especially important for more deprived areas where obesity rates are substantially greater. Therefore, the implementation of the policy is successful at a larger scale in more deprived areas. Another important point to consider is that this intervention provides opportunity for people to be educated on the topic of healthy foods and drinks consumption, where they may have not previously had the resources or time to learn about.
So recommendations to improve the uptake of the National Healthy Food and Drink Policy in Māori and Pacific communities would start with informing existing Māori and Pacific community leaders about the intervention, then organizing workshops to teach people in the community about it, and educating people about what foods are in what zone, and then hopefully implement the policy in school canteens so that a majority of the food that is provided is in the green and yellow zone. This means that kids and their parents will be able to better their lifestyles with healthy food choices and spread the message around to their friends and families, which improves the availability and uptake of the intervention in these communities. In terms of the Hader matrix or the cost component, implementing this recommendation means there'll be expenses with running the workshops. Individuals also have to bear the cost of higher priced healthier food, which is not ideal as many are of lower socioeconomic status. Canteens have to pay more for healthier food, which means in turn children have to pay more for lunches at school, and overall making healthier food choices more costly. However, if there's a budget given from the government, this will reduce the cost of workshops, and in the long run, eating healthier will result in less health problems, so less money is spent on healthcare.
We can also evaluate the preferences of the affected community or individuals. So it's important to consider if the intervention is suitable for that population. If a population is opposed to the strategy, many will not follow it, therefore the intervention will not be as successful. So reasons for opposition may be that it's time consuming to make healthier meals, and this is not suitable for a busy lifestyle. It's also costly to buy healthier foods and easier to buy cheaper unhealthy food. Reasons for compliance will be that you have an overall healthier lifestyle for yourself and your family, and this leads to less health complications in the future. In conclusion, overall, our recommendation of working with Māori and Pacifica leaders and communities would increase the uptake of the intervention, the Healthy Food and Drink Policy. By teaching individuals to make healthier eating choices, the risk factor of obesity in low SES communities can be reduced, and thus help to decrease the prevalence of back pain in New Zealand.
Tēnā koutou, thanks for watching Team Homiez.